Good morning. Thanks for joining our weekly Friday morning EpiCH webinar. We have a special guest today from Columbia University, Dr. Jeff Shaman, to talk to us about COVID modeling and other issues. And maybe we'll hear a bit about influenza also. And he is going to be introduced by our faculty member here, Ryan Demmer. And then Ryan will also join the discussion as a moderator later on. So I'll turn it over to Ryan now.
Thanks, Mark. Good morning, everyone. So I'm extremely excited to introduce Dr. Jeffrey Shaman. Dr. Shaman is an associate professor in the Department of Environmental Health Sciences in the Mailman School of Public Health at Columbia University. And at Columbia, he also serves as the director of the Climate and Health Program. Dr. Shaman originally trained at Penn in biology, completed master's and PhD degrees in earth and environmental sciences at Columbia, and then moved on to Harvard for a national oceanic and atmospheric administration postdoc position. So after receiving training at nearly half of the Ivy institutions, he eventually made his way back to New York City to Columbia, where his group now studies environmental determinants of health with a strong focus on infectious diseases. And he does this really unique mixture of climate science and epidemiology, and specifically develops dynamical and statistical modeling techniques to simulate and forecast infectious diseases. So in the context of SARS-CoV-2 modeling, many of you may recall seeing him on CNN this summer when work by Dr. Shaman's group estimated that delayed shutdowns early in the pandemic cost nearly 36,000 lives. And I guess I'll maybe conclude by saying that what I might respect most about Jeff's work is his unique combination of training, which I think qualifies him both as a meteorologist and an epidemiologist. And in that sense, his qualifications position him to tell you whether or not your wedding day will be ruined due to either rain or COVID. So thank you very much for being here today, Jeff. We really appreciate it and looking forward to the talk. So over to you.
Thanks for introducing me. I would hope that the message would be a little more upbeat. Maybe I could tell that the wedding day will be a success because there will be no COVID and it'll be a sunny day rather than the negatives. So thank you for having me. I am going to share my screen and dive right into some slides here that I'm going to tell you a little bit about some of the work that we have done on, let me just get this out of the way here, on COVID out of the gate initially. So I'm going to be talking about some transmission dynamics of SARS-CoV-2 and the model inference and projections that we have been doing. I'm going to first contextualize this by telling you a little bit about some of the other infectious diseases we brought these same methods to bear on. This is work that's been funded broadly by a range of funders. I put this up front because if I don't, I forget it. And it's work that's been carried out with a number of collaborators, many of whom are listed here. Hopefully all who are in this talk are listed here. So I'm going to dive right in. So we had found that influenza, looking at the influenza virus specifically, that it is modulated by humidity conditions, it seems. That if you measure and look at the specific humidity in the atmosphere, if you do laboratory tests, you can find that the viability of the virus actually doesn't do as well as conditions become more humid. Now, during the wintertime, it tends to be drier in places like Minnesota and New York, and that is conducive to the survival, the viability of this virus, and it facilitates the transmission of it between hosts. This is a phenomenon that's been shown for 80, 90 years. It's not entirely conclusive whether it's strictly at lower humidity conditions or lower and higher humidity conditions that it's favorable. In other words, the minimum of survival may be at some intermediate humidity level. But there have been laboratory experiments looking at the viability of the virus. There have been laboratory experiments looking at its lethality to animal models, to the transmission rates between animal models. And using all this and putting it into a mathematical model, we could see that we could actually drive a mathematical model using observed humidity conditions and reproduce the seasonal cycle of influenza with reasonable fidelity. And you can see that we've done that here for 5 states that have really disparate climates when it comes to the amount of humidity in the air. And specific humidity is a mass-based measure of how much water vapor is in the air. And it shows you Florida, which is subtropical, Arizona, which is desert-like, Washington, which has that funny Pacific Northwest climate, and Illinois and New York. And in all 5 of them, we are able to use a humidity-forced model to describe the average seasonal cycle of influenza. So we're able to build a rudimentary model that actually can say what happens on average. But we then asked ourselves at this point when we were doing this research, and I'm going through it quickly because I want to get to a few other things here, is can we actually predict individual outbreaks? Can we actually take the model that can describe the average cycle of how flu manifests such that it's dominant in the wintertime and not as abundant or incident in the summer? And can we actually predict individual outbreaks? And the answer is actually no. You can't just take a model and run it forward without doing other things to it and actually make a sensible, skillful prediction of what's going to happen. And the reason why is that infectious disease dynamics, flu in particular here, are nonlinear and they're irregular. And if you look at this plot on the right, what it shows you is an estimate of influenza activity measured by a proxy estimate of influenza-like illness. And it shows outbreaks over different years. The yellow one you can discount because that was the second wave of the 2009 pandemic. But the other lines all are seasonal influenza outbreaks in New York City. And what you can see is they're highly variable. Sometimes they're very early, they can be very tall peaks, they can have very long durations, they can have a lot of area under the curve, they can be very shallow. And that nonlinearity that maps onto this irregularity of the flu outbreaks is very difficult to predict. It's difficult to make forecasts of a nonlinear system just using a dynamical model describing those nonlinear dynamics. And that's because it's very sensitive to initial conditions and errors in the system, as we'll see. Now, we said to ourselves, can we predict it using the model that we'd used, as I showed you right there, to describe the seasonal cycle of influenza? And the answer was no. But then we said to ourselves, well, what about other systems? Aren't there other systems that have this problem of irregularity and nonlinear dynamics where they are capable of making skillful forecasts? And the answer is yes, there is one. And the big one that we know about is weather prediction. And this is a system where it is highly nonlinear, more so than infectious diseases, and yet they're able to make predictions of the outcomes of the atmosphere on reasonable timescales such that this is a really integrated portion of our lives where we always check the weather, most of us, in terms of what we're going to do, planning our weddings, obviously, but more so thinking about, do we need to take an umbrella today? How much clothing do we put on, etc. So how do they do it? Well, in order to do it in weather prediction, they used 3 basic ingredients. And we said to ourselves, well, if we're going to actually try to make forecasts of influenza, we need to mimic their strategy and use similar ingredients. So those 3 ingredients are as follows. The first is an observationally validated model describing the dynamics of the system. For weather, that's a model that describes the dynamics, thermodynamics, and radiative processes of the atmosphere. For flu, if we're going to try to make a prediction of influenza, we need a model that describes the transmission dynamics of flu as it moves through a local population. The second thing we need is observations. For weather, again, they use everything they can get their hands on. They use ground-based stations telling them about temperature, surface pressure, rainfall levels, wind speed, humidity levels. They use balloon soundings. They use satellite estimates, ocean buoys, ships, planes, anything that's making a measurement. They'll take that information in and they'll use that to inform the model. Now, we're going to use estimates as well, but for influenza, they're not as rich as they are for the weather. So we're going to have to use something like what you see in that upper right plot, which is a time series of influenza-like illness as an estimate for how much influenza activity there is from the past up to the present. Now, the last thing you need to make this sort of model inference framework work is a method for combining the observations into the model, for using it in an informed fashion in order to get the model to better replicate what's actually going on. And these methods are Bayesian inference methods, typically statistical algorithms that are often called data assimilation methods that are used to rigorously combine the observations and the model. So to spell this out for what we're going to do with flu, we're going to take our very simple humidity-forced compartmental model, which is what gave us that result that you saw on the first slide, where we were able to describe the average cycle of influenza activity in those states. And we're going to actually try to apply it here. We know that it can present and actually represent the average cycle, but by itself, it can't make predictions alone. But maybe we can actually gin it up a bit with these other ingredients and make a skillful forecast of an outcome that way. So this is just a simple 2-variable nonlinear oscillator. It divides the population into compartments or classes, those who are susceptible, those who are infected, and those who are recovered from, in this instance, the flu. There's an additional S on the end because people can go from recovered back to susceptible due to waning immunity or immune escape processes. And then there are these Greek letters that are actually guiding the transition rates between the compartments. And those transition rates are unknown and they're variable because there are different populations that have different susceptibilities, and they're going to have different contact rates, excuse me, is really what I meant to say. Or there are properties of the virus that are protean, they change over time, and we're going to have to estimate those on the fly. The second ingredient, as I said, are observations. And here we're going to use something like influenza-like illness, but we're going to gin this up as well. We're going to actually combine that diagnostic, which is not specific for flu and captures a lot of things like rhinovirus and respiratory syncytial virus as well, which produce similar symptoms. It's a syndromic surveillance. And we're going to multiply it by observed virological testing that shows us the positivity rate for the same week. So if we multiply the positivity rate times the ILI, we call that ILI plus. And what it does is it filters out some of the signals from other respiratory infections, such as rhinovirus. If you look at the time series and below, the blue shows you ILI only, ILI plus is shown in green. You'll notice that there's a different y-axis scale there. And so importantly, it's cutting out a lot of extraneous infections due to other agents. And it's also cutting off the early signal you see due to things like rhinovirus that exist or circulate more commonly in the fall. So we're going to use ILI plus as our estimate of influenza activity as our observation. We get this on a weekly basis. We can get this estimates for this at the municipal scale, at the state scale, regionally and nationally in the United States. The last thing, as I said, are going to be these data assimilation methods. And these data assimilation methods go by lots of names, and there are lots of variants of them. They're all recursive iterative filtering methods in which you're trying to entrain observations in a statistically rigorous fashion into an evolving model construct. They go by names like particle filters and Kalman filters and variational methods. And they're used in a lot of disciplines, including engineering design. They're used to help, for instance, the Mars rovers go about and fill up a picture of what they're contending with using something that includes a particle filter, for instance. And they're used in numerical weather prediction as well. So why do we do this? Why do we take this model, combine it with observations, and use it by using these data assimilation methods in order to do something before generating a forecast? And the reason why is that we're trying to reduce error. And error is the bane of forecasting because it produces uncertainty, highly spaced and spread out forecasts, and it can send things on the completely wrong trajectory. And this is particularly problematic when you have a nonlinear system. And so errors in a model structure, the model parameters, those transitions between compartments, and the initial model state, if they're too large or even if they're small, they can amplify through time. And the consequence is that if you leave the model to its own devices without some control on this error, if this is the true outcome in black, you might do something like this in your model in some abstract state space. To make it look a little more epidemiological, let's say this black outbreak here is the true outcome. If you make a forecast and it is this red forecast, and those are weeks, let's say, on the x-axis, that's a very bad forecast. You are completely off. And it's even more egregious if you made this forecast, say, at week 15, because if you made it at week 15, that means you weren't paying attention to the uptick in activity that took place from weeks 9 through 15. You didn't use that information to inform the model that there's something going on here, and you need to follow the outcomes that have taken place already to have an understanding of what kind of dynamics are at play here and what kind of processes may unfold in the future. So that's the name of the game. The name of the game is to try to minimize error using the data assimilation and real-time observations. We use them to recursively adjust and optimize a mathematical model. This is an inference problem. We're estimating unobserved state variables, this is the number of susceptible, the number of infected, and we're estimating parameters in the model that guide things like how long a person stays infectious, what's the contact rate between people, and how transmissible is this virus. Now, if the data are rich enough in the observations for the system, we might be able to identify the state variables and parameters well enough so that we can make a more accurate ensemble prediction of what's going to happen. So the aim is to take observations from the past all the way up to the present and to use them to inform the model as to how the outbreak has manifested thus far. And the aim is that if you can get the model so that it's capable of simulating what has taken place in the past, and we're talking the recent past, not 10 years ago, but if it's a flu outbreak in February, what's happened since from October to the beginning of January, okay? We use that information. If it can simulate that well, then you're gonna have a better chance of simulating and forecasting what will actually happen in the future. So here's an example of a real-time forecast when it works. This is something we did during 2012-13. It shows it for Salt Lake City, Utah in the middle of December. Week 50 is about December 15th, roughly. And what you see are the black X's are observations that we had in hand at the time. And the blue line there is the mean posterior of 150 200 member ensembles. Now we use ensembles because that's how these filters, those algorithms I talked about for data assimilation, are set up to statistically work. It's the most effective way of doing it, where you have a number of simulations of the system running simultaneously and communicating with each other through the algorithm, and that's how you optimize it. We do it repeatedly, 150 of them, because we want to know how sensitive it is to the initial conditions back in weeks 32, 34, 36. So what you see with the posterior is that the model, with this adjustment by the data assimilation, is capturing the observations from week 40 up to week 50. The forecasts are those gray lines, and that's where we break it apart, and we're showing each of the 150 200 member ensembles. So each gray line is the average of the 200 of a 200 member ensemble. And you can see that they're all basically conforming to the same prediction. So there's not a lot of sensitivity to that initial condition back 16 weeks ago. And what they do is they're saying, for the most part, that flu is going to peak in 5 weeks. And they show an overall duration and an area under the curve in terms of how much ILI plus there's going to occur at this time in Salt Lake City. What you can see in the red X's are the observations that we didn't have in hand at the time. And you can see that overall, the forecasts actually do a decent job. There's some things that might be better, but overall, they're getting the overall duration right. The area under the curve is good. They're saying that the flu will peak in 5 weeks, and in fact, it does. Now, that peak point is high, and it's above those gray lines. But as I'll show you in just a moment, that is actually not statistically out of the realm of the predicted possibility for this real-time forecast. And the thing is, we don't want to just say that we're making a prediction that flu will occur in 5 weeks. That's not informative enough, because you don't know if that's a good forecast or just the best guess that this model is making after some sort of optimization with this assimilation algorithm, but it's still not a very good forecast. We want to know how certain that forecast is. And that gets to the idea of a calibrated forecast, which is actually something that we're actually quite used to from weather prediction. In weather prediction, they don't just tell you it's going to rain tomorrow or it's not going to rain tomorrow. They'll tell you there's an 80% chance of rain or 30% or 50% chance of rain. And if you were to tally up all the days over the last 30 years in the Twin Cities where they've said there's an 80% chance of rain tomorrow, you'll find it rained on just about exactly 80% of those days. And you can go all the way down the line, 70, 60, 50, 40, and you'll find that those probabilities really line up for how often the event actually manifests. They're very well calibrated, and thus it's reliable and it's useful. So we want to be able to do the same thing here. We want to be able to say there's a 70% chance that flu is going to peak in 5 weeks versus a 10% chance that flu will peak in 5 weeks. Both of them are saying that our best guess is 5 weeks, but there's a much greater certainty associated with 70% that might be actionable and require that you could actually do something about it. So the way we get at that is we actually pull apart those ensembles. So what you're seeing in this spaghetti here is one of those gray lines you saw there, now represented as a magenta line, and we're showing all 200 members that make it up. And you can see there's a lot of disagreement between the individual ensemble members during this optimization problem in the process in blue and during the forecast period in green. However, we can use that disagreement to our advantage, and we were able to show that the more agreement there is, the more certainty there is in the forecast. And the less agreement there is, the less certainty there is. So we can give an expected likelihood for these forecasts. We can begin to actually say there's a 70% chance that flu will peak in 5 weeks in Salt Lake City. So we first did this for 108 cities in the US during the 2012-13 season, and we wanted to verify a number of issues. So are the forecasts more accurate than a simple expectation historical likelihood? Are those expected likelihoods I just talked about, the ability to make a calibrated forecast, are they being brought to bear, and does that actually appear to be true? And also, how far in the future can we make a forecast? For weather, for instance, there are very well-defined limits of predictability going out 2 weeks, that's it. You know, if you see a forecast going up 45 days, like what AccuWeather does, it's completely bunk. It's beyond the limits of predictability for the system. There's nothing there. So what is the limit of predictability here? How far out can we go and get some skillful predictions? What we found is that we were able to actually very much beat historical likelihoods, which are shown in the green and red at the bottom there. Those are the likelihood that you predict for these cities during 2012-13 based on when things have peaked in the past. And we can see that by week 52, which is the last week of December of the 2012-13 season, 63% of the cities were accurately forecasting when their peak would take place, and 84% of those cities peaked at week 2 of 2013 or later. So this was lead forecasts we're talking here. We were also able to show that the expected likelihoods were panning out and that we were able to make predictions up to 9 weeks in the future with accuracy. The system is not as nonlinear as the atmosphere, so we're able to make longer lead predictions. So once we did this, we said, well, we got a lot of work left. We were able to do this to some degree, but can we build a more reliable forecast model? Can we try alternate forms that bring in more bells and whistles and make the models more complicated and maybe bring more data in so that we can actually constrain those more complicated models? Because as you make the model more complex, you're going to need more data richness if you're really going to have an identifiable system. Can we improve the model optimization, those data assimilation algorithms? Can we actually translate this and provide it in a useful way for public health officials and hospital administrators, et cetera? So these are some of the problems that we've been dealing with. I'm just going to show you a few examples. We have an operational website in which we make forecasts of flu. You know, we're going to do that this year, but I suspect flu activity may be very suppressed as it was in, say, Australia, because of all the non-pharmaceutical interventions that are in place for COVID, which will probably affect flu just as much. We also, have made much more complicated models. This is a model that made predictions using Department of Defense data for influenza in 35 states, linked up by commuting and random movement, much higher dimensional structure. And we were able to actually improve in predictions by combining them and running them all in one model, and particularly improve the prediction of when the flu outbreaks started. Because if we know that the flu outbreaks have started in some states, we know that that's going to diffuse or move over through commuters and random visitors to the other locations. We've also made systems for West Nile virus. This is obviously a mosquito-borne disease, making predictions of both mosquito infection rates and human cases. And we've done scenario projections for Ebola during the 2014 outbreak in West Africa. Now, the systems that we've made for forecasting, this combination of a mathematical model with Bayesian inference, what it's doing is it's providing estimates of the critical epidemiological characteristics of the system in question. You use those then to make a projection into the future that becomes your forecast, which is hopefully reliable and calibrated. But that inference itself, without the forecast, is very useful because it tells us about critical properties of the virus or pathogen that we're studying in a way that other systems may not be able to do so. So just looking at model inference systems, just doing this whole thing of trying to estimate the parameters that represent critical epidemiological properties is in of itself a very useful exercise. So we applied this to looking at the spatial spread of Ebola in Sierra Leone, trying to understand how quickly it moved, how transmissible it was, how rapidly it was spreading out, and what the pathways had been. We've also used it in an incredibly high dimensional model. This is an agent-based or individual model of individuals in a Swedish hospital system, 66 hospitals, 750,000 people passing through this, actually 2.2 million patient visits over time to estimate the critical properties of methicillin-resistant Staphylococcus aureus, colonization, importation, infection, importation, and transmission dynamics within the hospital. And we're able to make those kinds of estimates here as well. So it's with that system in mind that we actually were confronted, we confronted COVID-19. And to understand our perspective on this, I want to tell you a little bit about another study we did, which was a field study in Manhattan. We called this project the Virome of Manhattan. And in this, we were trying to understand common respiratory viruses, not COVID-19. It happened and was put in place before it. But we had a number of aims of it, one of which was to try to understand asymptomatic infection rates and undocumented infection rates. And so to understand that, we had, in one instance, a cohort. And this had 214 individuals enrolled. variably from October 2016 to April 2018. So this is a 19-month period spanning 2 winter seasons when colds and flu are often in circulation. We did sampling at 2 daycares, a pediatric and adult ED at the medical center at Columbia University and a high school. And what we did with them is we asked each individual in the cohort to provide a daily record of their symptoms. They would enter it into directly into an electronic database over their phone on a daily basis, telling us on a Likert scale, none, mild, moderate, or severe, how they felt vis-a-vis 9 common cold symptoms. These are things like runny nose, sneezing, cough, sore throat, chills. They would rank them on this Likert scale, and they'd send it into this electronic database. So they'd also tell us at the same time if they had stayed home from work or school because of their symptoms, taken medicine, or gone to see a physician. So we're getting all this information. It takes them all 30 seconds to do it on a daily basis. In addition, regardless of how they felt, we would swab them once a week, take it back to the lab, and we would test it for 18 different respiratory viruses that are common. What you're seeing are the results for this cohort. We've grouped the respiratory viruses like RSV A and B into one category, that's just RSV there. And you're seeing in the second column where it says episodes, the number of infectious episodes we documented. Now, infectious episode is a group of consecutive weekly specimens from an individual that were positive for the same virus. We also allowed a 1-week gap in case there was false negatives or temporary low shedding. But using this criterion, we found that there were 32 infectious episodes with flu, 30 with parainfluenza, 275 with rhinovirus, 137 with the endemic coronaviruses, OC43, HKU1, and the other 2. Now, that's the number that we see there. But the critical thing that we're seeing here, and one of which is not shown, is that we saw that the majority of infections were asymptomatic, and that defining asymptomatic was actually very tricky because there were some individuals who on a daily basis always reported some symptoms. They were never without symptoms. Maybe they had chronic rhinitis, maybe they had fibromyalgia, maybe they were just a hypochondriac. Whatever it was, they were always reporting symptoms. Then we had other individuals who never reported symptoms. No matter what pathogen we detected in their system, they wouldn't report symptoms. So, symptoms are supposed to be self-reported, but they're highly biased by that. And actually having a definition of asymptomatic is very challenging. So we try lots of definitions of it. But even as we try that, we see that the majority of infections are asymptomatic by any definition that you would use that would seem to be reasonable. And it's actually a very squirrely thing to use, given that some people are always reporting symptoms. But what is more clear is whether or not a person stays home from work or school, or they go to see a doctor because of their symptoms and their infection. And it's that last one, going to see a doctor, that actually allows you to be documented by our surveillance system, which is passive. That's the only place where somebody's going to be identified as having influenza-like illness, where they're possibly going to be tested and find out whether it's flu or RSV or some other pathogen. Now, if you look at the third column, it says MA, that means medically attended. And that shows you the number of episodes that were medically attended for each of the viruses. The fourth column puts this together. It's the probability of being medically attended given an infection with virus I. So what you see for influenza is that's the highest one. And it's less than a quarter of the infections people actually went to see the doctor because of their symptoms at some point during their infectious episode. If you look at the low one, that's the endemic coronaviruses, which cause the common cold. There, it's only 1 in 25 persons would actually see the doctor. And what this shows us is that the majority of infections with these common respiratory pathogens are not documented. People never know they have them, and they're not aware or recorded in our public health systems that these are circulating. Furthermore, because the symptoms manifest mildly for most infections, including influenza, including human metapneumovirus, the people aren't doing anything to disrupt their routines. They are not staying home from work or school. And even if they do stay home, mind you, they're only doing it for a couple of days, not the period of time when they're contagious. So what does this mean? It means people are out and about in the community while they are contagious. They do what you and I do when we get a cold in the wintertime, which is nothing. If we have a little sore throat or some body aches or something like that, you just bull on through it. You go to work, you go to school, You go out to restaurants, you go shopping. If you have a business trip, maybe you'll take some cold medicine, but you get on the airplane. And what are you doing when you do this? You are taking the virus out in the community and you're spreading it out and about. And it's this property of the viruses, the fact that they're manifesting in most people as asymptomatic or mildly symptomatic infections. And yet these people are contagious with detectable infection that allows these viruses to get around. They are still contagious. I'll just tell you very briefly that we had another arm of this where we sampled at a popular tourist destination in New York City. I'm not allowed to give the name, but we sampled over 4,000 people. We would just go up to them at the tourist destination. We'd ask them to enroll. We would take their medical history. We'd ask them what their symptoms had been for those common cold symptoms over the last 48 hours, and we would swab them. What we found is that, in February, 1 in 9 persons out and about, these are ambulatory adults, was shedding a common respiratory virus. And so people take this out all the time with them. All right, so what does this have to do with COVID? Well, when we saw COVID in January, when the world learned of it December 31st, and we saw how quickly it was moving around within China, how quickly it left the epicenter and was emerging in all these cities throughout China, and then hopping on airplanes and going to Thailand and Korea and Japan and the US, we immediately said to ourselves, this is behaving like a common respiratory pathogen. This is spreading, and if it's going to spread that quickly, that means that the majority of people who are spreading it aren't even aware that they have this infection, which means that they're either mildly or asymptomatic, or maybe they're pre-symptomatically shedding. They're shedding the virus before their symptoms really become intense. So what we did is we reached into our arsenal of model inference approaches and we said, let's see if we can estimate this. And we build what's called a metapopulation model. It's like the one that I showed you that was used with the DoD data for influenza to forecast flu in both space and time. And we set up a network model representing the transmission dynamics of COVID-19, SARS-CoV-2, at 375 cities in China. We use Tencent travel data, and Tencent is a location-based service that's used, that's in popular apps on people's cell phones in China, like QQ and WeChat. We use Tencent chain records to show how travel movements manifest in the run-up to the Spring Festival, which is the time period we were looking at. We coupled the model with data assimilation methods, and we used daily observations of cases from all 375 cities we're representing. And we're going to use this to simulate and infer the parameters from January 10th to 23rd. We chose a very short 14-day period to look at for 2 reasons. Firstly, before January 10th, there wasn't enough activity to really get a good signal, so we can't really start earlier than that. And then on January 23rd, that's when the Chinese government issued lockdown orders in Wuhan city. And in doing so, they stopped all movement in and out of the city. And within a few days, they had locked down over, almost 3/4 of the country was under essentially shelter-in-place orders in China. Now, we're looking at it, therefore, during this period because it's prior to travel restrictions, and it tells us something about how the virus transmits in its native element, unimpeded for the most part in Chinese society, given their connection patterns, population density, and everything else. Now, the other critical thing is within this model, which is shown in those differential equations there, we are separately representing documented and undocumented infections. The documented infections are the cases for which we have observations. The undocumented infections are unknown, and we're going to try to estimate those. And the model, in addition, has separate contagiousnesses for documented and undocumented infections. We're not going to assume that they're equally contagious with the virus, and that there may be some association between symptom severity and how much virus you're putting out in the world and how transmissible you are with that virus. So when we build a system like this, we have to check whether the things that we want to infer, which are the critical parameters, those epidemiological parameters within the model, can actually be identified. So we do a bunch of synthetic tests where we take the model and in free simulation, we impose initial conditions and a set of parameters, and we create an outbreak. And then we take the outbreak observations of cases and we feed it into the full model inference system, and we see whether or not we can estimate those parameters. And if we estimate those parameters accurately and consistently for many, many outbreaks, and trying to break the model apart and reduce its complexity, we find out whether or not the data are rich enough to actually provide a reasonable estimate of these properties that we're so interested in. All right. And so what you're seeing here is one of the results from one of these synthetic tests. The red lines are the truths for each of the parameters. Parameter beta is the contact rate. Parameter mu is the adjustment of that contact rate or contagiousness for undocumented infections. Theta is a travel adjustment parameter for the 10-cent data. Z is the latency period. Alpha is the reporting or ascertainment rate, which is what fraction of infections are going to be confirmed cases. And D is the infectious period. On the right, lower right, it shows you it shows you the reproductive number, which is actually a combination of 4 of these parameters. That's how you actually estimate it for this model. And what you're seeing in red is the truth, and the blue shows you the estimate provided by the model inference system. And you can see for all 6 parameters, as well as the compound parameter, the effective reproductive number, we are able to capture it within the 95% credible interval. And we did this over and over and over again for lots of different combinations of these parameters, and we were consistently able to do it to the point where we were able to convince ourselves and ultimately reviewers that we had an identifiable system. We then applied it to the actual data. And in applying it to the actual data, I want you to pay attention to 2 parameters. Firstly, alpha, the reporting rate, that ascertainment rate. We get a value of 0.14 as our estimate, which means we're estimating that 14% of infections are documented. Conversely, that means 86% of the infections during this 14-day period were undocumented. Secondly, we're estimating that mu, which is the relative transmissibility of the undocumented infections, and we see that on average, they're about half as contagious as the documented infections. Now, we can then take those parameter estimates we got in that table, plug them into the model and run it in free simulation and see if it produces outbreaks that look like reality. When we do that, that is indeed what we get. That's what this is showing you here. You see the outbreak in terms of the national daily cases, and that's shown the observations are X's, and then 100 simulations, you can see in box and whiskers the spread of those simulations, how they're capturing within the 95% prediction interval the observations quite well. The same goes for looking just at Wuhan City within this model, as well as Hubei province, which is the province in which Wuhan City exists. And on the lower right, it shows you the observations as well as the simulations of the number of cities that have 10 or more cumulative incidents on a given date. So overall, the fitting is working well, and it's allowing us to generate simulations that look like reality. So the parameters look good, and they're able to actually work. But we also, because it's a model, can actually play games with it and do some counterfactual simulations. We can say, all right, but what if we shut off the ability of those undocumented infections to transmit the virus? What if we set their contagiousness to 0? Are we still going to see an outbreak of the magnitude that we saw thus far in China? And the answer when we did the simulations was no. So you can see the simulations in red with the full model parameter estimates, and in blue where we've shut mu down to 0. When we do that, 80% of the confirmed cases disappear. So what does this mean? It means that even though per person undocumented infections are less contagious than documented, because there's so many more undocumented infections, they are responsible for the lion's share of the transmission of this disease. So what does this all mean? Well, when we did this, and we did this in late January, we said to ourselves, we're definitively going to have a pandemic in our minds. And the reason why is that this virus has the critical characteristics epidemiologically that mean it's going to be a pandemic. Firstly, it is a novel respiratory pathogen to which almost all the world's population has no pre-existing immunity, as far as we know. Secondly, the majority of the infections it causes are mild or asymptomatic. They're undocumented, and people are unwittingly sharing the virus by moving around. In addition, we are also able to show, and I didn't show this here, that there was considerable pre-symptomatic shedding as well. Thirdly, and that property is what allows it to get around. It behaves like a common cold that way. The third problem, of course, is that there are still a lot of documented infections. 1 in 7 is a large number when you consider the world's population, and this moving through 50, 60, 70% of that. And there is a high case fatality rate among those documented infections. This table here shows how it actually falls within the other known coronaviruses that have afflicted humans. SARS-1 emerged in 2003, and it really didn't have any subclinical infections. Almost all infections were documented, and people didn't shed pre-symptomatically. And those properties made it less capable of getting around. It could be identified as to who was infected, and we were able to circumscribe it and control it. MERS came out in like 2013, 14, and there were some mild asymptomatic infections, not as the same rate that we're seeing for SARS-2 at all. But MERS wasn't that transmissible. That was its problem. It didn't have a good reproductive number for getting around very well, and so it was able to be circumscribed and controlled. Then we have the seasonal coronaviruses, 229E, OC43, NL63, and HKU1. Those are the ones that cause all those infection events I showed you in the table in the virome study. These are very mild. They don't cause a lot of problems because of that. And so because of being so mild, we don't concern ourselves with them that much, but they get around all the time because almost all their infections are undocumented. So SARS-2 falls in between SARS-1 and MERS and these seasonal coronaviruses. It hits this sweet spot and it makes it a very challenging proposition to control. And I was asked to go 40 minutes, so I'm going to stop here and take questions now. Thank you for your time.
That was great. Thank you so much, Jeff. All right, so we're going to open the floor for questions. You can put questions either in the chat, and I'm happy to read them. You can raise your hand, and Mark or I will unmute you to go ahead and ask your question. So the floor is open. And as people are formulating their thoughts, I can maybe start with one. You know, the role of asymptomatic transmission is so important, as you've documented, and the methods you're using to really show that and quantify how important it is remarkable. So what I'm curious about is your thought on schools, and what is going to happen after we're getting 2 or 3 months into kids in schools, particularly in New York. I think you guys were delayed by a few weeks, but a lot of schools are now back in person. And how is that going to drive this, given the fact that most of the kids tend to be asymptomatic or have mild symptoms?
You know, and that's a big concern. And it's very hard to study in isolation because there are a lot of other processes at play as we move further and further into the winter that are unfortunately working against us. I mean, yesterday we had 71,000 cases reported in the United States, which is the highest number since July and like the 4th or 5th highest daily number that we've seen. So we are back in the throes of it already. And I think it could get worse, unfortunately. The virus is most likely transmitted indoors. It's getting colder. We're spending more time indoors. It's probably more viable in colder weather. The endemic coronaviruses are, and there's mounting evidence that this is sensitive to humidity and sunlight conditions. And those are going to favor the transmissibility and the viability of this virus in the wintertime as well. And then we have universities and schools in session. But as you're saying, kids have been sort of a conundrum because their case rate is so low and their case fatality rate even is low as well. And this is a disease that seems to manifest in those middle age, and it seems to really hurt those and kill those who are elderly, okay? And so it has a very strong age sensitivity in terms of how it manifests. And the question has been, are children actually part of the transmission cycle, or are they somewhat of a dead end? If they're asymptomatic, do we need to bother with it? Is opening schools not a problem? Because even if the kids get it, they're not transmitting it to other people. I think, you know, from a very ad hoc way, you could say, look, if you were to look at the extreme possibilities, one is that kids are just as contagious as adults. And the other is that they're not contagious at all. Those are your two end members, right? In all likelihood, and the evidence speaks to this, it falls somewhere in between, which means that the young kids, and we're talking kids less than 10 years of age now, all right, are not as contagious, perhaps, as adults, but it doesn't mean that they're not contagious. And they are taught by adults. And some of those adults have comorbidities and chronic conditions, hypertension and high blood pressure, diabetes. You put those together and you're allowing the kids to spread the disease amongst themselves, take it to their teachers, to the administrators in the school, and to their communities. It's probably not as dangerous as opening universities, to be perfectly honest, or high schools, where we clearly see that kids are just about as contagious at those ages as they are when they're in their 20s to 40s, let's say. But it's a problem. It's something we have to be very careful about. So there's an enormous balancing act here, because undoubtedly not having in kids comes with enormous educational, social, and emotional cost. Schools provide an important function that way. And additionally, for many families, they can't afford childcare. So they're really caught in a bind as to how they're going to work and actually have their kids taken care of in those situations. So not having schools open is incredibly challenging. But from a disease perspective, opening schools, excuse me, you have to admit, firstly, that is going to increase opportunities for the virus to transmit. Now, whether you can actually affect control measures, social distancing, thinning of class sizes, bubbling of schools, bubbling of classrooms, wearing a face mask are going to be sufficient to control is an open question. And we will continue to see that. We have real striking examples of where it's fallen apart, particularly from high schools, but also from day camps with young kids, occasionally from preschools, certainly from universities. Very challenging problem.
Absolutely. Thank you. We have some questions in the chat. Rebecca Scholar is asking, is there evidence to suggest that those with T cells to coronaviruses contract COVID-2 at a lower rate than those without pre-existing T cells? And then a follow-up to that, is there evidence to suggest that those with T cells who do contract COVID-2 develop antibodies to COVID-2 at lower rates than those without T cells who contract COVID-2?
So that's a great question, and I'm only going to be able to partially answer it. So look, T cells are part of your adaptive immune response, and it's one indicator that you may have protection against something. And there was a study that was done on blood bank samples that showed within that a third of the people who had blood in that repository had some level of cross protection from existing T cells in their blood. And this is prior to the emergence of COVID-19 that these collections were taken. So that would suggest that maybe there is some pre-existing immunity out there, and that maybe herd immunity will be attained at a level lower than what we think might be, or in the absence of it, it would have to be. It could still have to be 60, 70%, and that could be predicated on the fact that we already have a partially protected population. I have not followed this line of research to know if there's been a follow-up to see whether people who had banked samples that show that some cross protection prior to this pandemic have had a lower rate of infection, B, milder symptoms, and what their memory B cell and B cells responses were to those infections. I'm not aware of a study of that, though. There may be some out there, and I just may be ignorant of it. So I don't know. But these are really important questions to understand. But it also gets at this notion of herd immunity, which people have contested about quite a bit. And there have been some modeling studies that said, mathematically, we can develop a system where there's enough heterogeneity amongst contexts where you might only need 10, 20% of the population infected, and then you're going to be done with this. And maybe that's why we saw New York City die out and not have any further outbreaks. And the same thing happened in Europe and in Sweden and places like that, where they really did the herd immunity. Well, Sweden had its highest recorded number of cases yesterday. And the day before that, I think they did also. And they're having second waves. Europe is absolutely rocked by it right now. When we see places that have really been cut through by this, like Manaus, Brazil, it appears 44 to 66% of people have been infected by it within that population of Manaus. And then there's a really good study preprint on the country of Qatar, which has 60% of its population are migrant workers from South Asia for the most part, and they live in dormitory style housing, and they eat in cafeterias. 70% of the people there have been infected in that population. It's a population of 1.7 million people. And I think it's actually higher than that because they did the sampling over a period of time and the outbreak was still taking place. So it's probably 75, 80% of people have been infected. So getting to herd immunity doesn't seem like something that we're going to be able to get away with without a vaccine where, oh, we're done with it. It's not manifesting that way, unfortunately.
Another question from Jeff Johnson, wondering how do models deal with control measures that are introduced and removed over the course of the outbreak?
That's a great question. So, the reason why we did this study January 10th through 23rd is there wasn't that much control done. Obviously there is, but it wasn't on the extent of travel restrictions, shelter in place orders, or anything like that. Obviously there's increased awareness and people being fearful, and there may be some modulation of people's behavior. It's very difficult to account for that, but what we're looking at is an average transmissibility, contact rate, during that 14-day window there. Now, when we're dealing with projections and we're talking about people who make what they think are forecasts, they're not forecasts. And I get into fights with people about this quite a bit. A forecast needs to be calibrated in the fashion that I talked about here, where you have some reliability as to what you're predicting, and it's predicated on a stationary system. We don't change the weather, and we can make very reliable calibrated predictions of the weather. For seasonal flu, we were able to make reliable predictions because what society did to combat flu, the seasonal flu, was fairly consistent on a year-to-year basis, okay? Wasn't that much movement on it. With COVID-19, things are changing all the time. And the projections that we have to make are conditional, they're scenarios. They're predicated on, well, if society does this over the next 4 to 6 weeks in terms of control, this is what we're expecting to see. If the society ratchets up control, given where they are now, this is where we're going to be. If they relax it, like Florida opening up their schools and their restaurants at 100% capacity, and they're now going through the roof again, then this is what we might expect to see. So all those projections are really offering guardrails. They're telling you outcomes that could happen that are within the realm of possibility, given certain scenarios. But they're so conditioned on what we do collectively and individually that they are not forecasts, and pretending that they are is really foolish. I have real strong objections to those groups that have come in now and they're calling them forecasts and they're going out 6 months in the future. There's no way you can know what society is going to do. And so much of what's going to actually manifest is conditioned on what we do. It is in our control. We could go down the path of what South Korea or Thailand or Vietnam have affected, all right? Or we can go the way we're going, which is, to bumble along incompetently.
Very well put. Well, that provides a nice segue, your comment about forecasting too far into the future, into the next question, which I'm sure will be easy to answer from David Jacobs, who is just asking, how do you see COVID-19 ending?
Well, I think it's going to be endemic. I think we're going to be dealing with it, but the question is, you could argue it's already endemic. I mean, what does it mean to be endemic? Is it going to be endemic the way measles is? Is it going to be endemic the way malaria is, or West Nile virus is? And so I see a lot of possible scenarios. And we had a paper out last week in Science where we speculated on that. The title is, will SARS-CoV-2 become endemic? And there are a lot of factors playing into it. What kind of vaccine we can develop, how effective that is, whether we can distribute it broadly in the world. Does it need a cold chain? Can it be taken to places that are remote? Or is it something more like the flu vaccine, where it's partially effective, but not great, and you have to get it over and over again? What are the rates of repeat infection? That's a really critical issue. Are people, like they are with the endemic coronaviruses, OC43 and the like, going to be infected over and over again with it? If so, how often? And if so, are their symptoms equally likely, less likely, or more likely to be severe? At this point, we have about 24 people who've been documented, we think, really to have had repeat infections. But I imagine there are many, many more. I get people who email me all the time and say, I lost my sense of smell and taste with this cold back in February. I swear to God it was COVID, but I didn't know. And I just got it again, and I have a confirmed positive, and here it is, September, and you're like, that could very well be a repeat infection or not. I don't know. But what we are seeing is that they do occur. We have documented proof by sequence that they're distinct variants that people have had. And so the question is this going to be commonplace? And if so, at what timescales and what's the severity? One of the persons that we've seen, 9 of the people, had more severe reactions on their second infection than on their first. And one person died the second time. So all those things are going to come together to determine, is this something we're going to be dealing with for a long time? I think we're in for a long winter in the near term. I think the next 5-6 months, we should not be expecting that we're going to have a vaccine or a treatment that comes out that's going to be broadly distributed at the level that's going to be able to really make an impact. It would be great if it does, but that seems a little fast for me. But we could be dealing with this if we only get partially effective pharmaceutical interventions for another couple of years. So I can see all those outcomes.
Long road. Here I was expecting to get a vaccination at the ballot booth.
Yeah.
A week and a half. Unfortunately not.
Only
Another
if you vote the right way though, right?
Correct. Yeah, that's right. Kumi Smith is asking, in the examples of MRSA and Ebola, what specific things did you learn about the pathogens or their transmissive properties from the model exercises you shared?
Well, let me just say, look at the MRSA one. For the MRSA one, we were able to estimate how importation dominated initially during the outbreak. And then really in the meat of it, it was nosocomial transmission. And then as it tailed off and the hospital ratcheted up its controls for MRSA, the hospital system, it went back to importation. And we could see what those relative pressures were. The other thing that we're able to do in that model system is we're able to estimate who is more likely to be colonized. So the majority of MRSA infections are not identified, they're undocumented. People are colonized with, this asymptomatic colonization that really hasn't set up an infection that's problematic. But we're able to identify who might be what would be the most efficient way of testing people based on who we think is most likely to have a colonization based on this model inference process. So that's one of the really critical things that we can do, and we're trying to refine that right now because we continue to work on MRSA and other AMRs.
Another question from Melissa Martinson. What relative role do each of the following play in severe disease and death? Viral load, genetic susceptibility, comorbidities, and prior similar exposures?
Oh, they all probably play some role. And the answer is that's a great question, and it's very complicated. One of the points of the Virome project was to try to get at the genetic basis of immune response to respiratory infections. But overlaid on that are all those complexities she laid out. Viral load is a lot of people think it's important, and I could see why that is. Where you get the infection, whether you're getting it in your lower respiratory tract, if it makes ingress there as an aerosol versus the upper respiratory tract as a droplet, may be very important as well. Pre-existing immunity and prior exposure are going to be incredibly important, and that adds complexities at a variety of timescales. There's this concept of original antigenic sin in influenza, where the first influenza virus you're subject to really imprints which classes of virus you're going to be able to mount a better response to, and those that you're not going to be able to mount a response to. And then there was one other thing she put in there, and I'm already blanking on it because I talk too much.
Comorbidities.
Comorbidities, yeah. I mean, comorbidities are enormous. And it's clearly for SARS-CoV-2, this is huge. The infection fatality rate we've estimated in New York City for those under 25 is 3 orders of magnitude less than those over 75. So, and people who are older have more comorbidities.
A question from Steve Stovitz. Any evidence that absorbing a lower dose of the virus leads to lower intensity of symptoms? Example, lower case fatality rate in places with lower probabilities.
That follows on the preceding question in terms of the infection dose. I haven't been following that literature well, so I'm going to have to punt on that one. I don't know what they've seen for SARS-CoV-2 in terms of this and what they've been able to document.
Great. Question from Diane Newmark-Steiner. Is there work being done to model or otherwise determine overall morbidity, mortality, societal impact due to not being in school or being socially isolated?
Absolutely. Lots and lots of people are looking at that. They're looking at the mental health aspects of it. A study just came out looking at suicide rates and found that they hadn't gone up yet, but calls to call line centers are through the roof. People needing someone to talk to. Michael Phelps advertises for this talk center, and I have a faculty whose daughter is like a clinical psychologist, and she works in the mental health ward at Bellevue, but she also does this on the side, working on them and talking to people. Just the call volume is unreal, and there have been documentation of that as well. Yeah. Great.
Well, we're at the hour. If I could ask just one more question, I've been very curious about, and we can maybe end with that. Mm-hmm. There's a lot of debate about the role of testing, and if we're thinking this could become endemic and we have a long road ahead, there's still a lot of time to actually do more in the realm of testing. So to what degree do you think that far more rapid testing in asymptomatic individuals is extremely important? Or is it less important? Because in most places in the country, we're still just focusing on symptomatic individuals. Yep. And your model showed very nicely that it's the asymptomatic individuals that are driving this, and no one seems to listen to that message.
Well, the problem is that right now, it is so pervasive and there's so much community transmission that we don't have the capacity to do that. It's too costly. If you have 70,000 cases a day, that means there are probably more than 500,000 infections acquired a day in the United States, okay? You can't keep up with that volume, and you can't do it even with a rapid test. The ability to keep track of all that and use that in a sensible test and trace fashion it's not there. What we really need to do is crush this virus early on before we got to these numbers, and then the testing and tracing really can work to your advantage. When you have it at lower numbers and you can use it to cluster bust or jump on flare-ups or whatnot, then it really becomes advantageous. So for instance, in New York City right now, we had flare-ups in the Orthodox Jewish communities in Brooklyn, associated with the high holy days there. And there, the testing and tracing can help because the infection rates are low enough in the New York City environment and the capacity was built up enough that they can actually make a dent and help in control of it. When you look at places like South Korea, they've been using this to really great effect to manage it in a very densely populated, modern, connected society. That's where I think it has the most capacity. But at the point where we are right now, I think we need more of a sledgehammer approach. If we're going to control this, we really need to go back to, people have proposed we need to shelter in place for 6 weeks. If we did a reset like that, we could do that, but nobody seems to have the political will to do that, given the economic costs associated with that. Unfortunately, it's a very difficult needle to thread here, which is you want to control the virus and you want to maintain a robust economy. But what we've seen around the world, and we've seen this since April, and that's the thing that's frustrating because people like me, at least, I've been saying this since April. You control the virus first, then you can reopen your economy, okay? We got so impatient for political reasons solely, really, and a lack of communication and expectation management, really a lack of leadership, to actually say that we let it go to states, and then they just started opening willy-nilly in May. And the consequence was the June-July outbreak that took place. And they didn't learn the lesson that this is not going to just go away because you wish it away. And that if you can control it and get yourself to the point where you control it at low enough levels, then a cautious approach to reopening, which a few states have done. A place like Vermont. Vermont's got the advantage of low population density and whatnot, and small, but they've been able to control this virus very well compared to the rest of the country. And they've really followed the South Korea's model in how they go about things. And that's to be cautious. Once you do that, the economy goes, the places where their economies are going right now are the ones that have controlled the virus.
Perfect. Well, with that, we're going to conclude and say thank you very much for taking the time to be here with us today. That was incredibly insightful and informative. I really appreciate it. Be well, and we'll be thinking about you in New York.
All right. Thank you. Be well, everybody. Take care. Bye-bye.
Thank you. Take care.